Many times, osteoporotic compression fracture develop delayed collapse due to ischemic necrosis, which is known as Kummell's disease. In Kummell's type 1 and type 2, a conservative treatment or a vertebroplasty can help, whereas type 3 is important because there is a significant collapse of the vertebral body and there is an involvement of posterior cortex as well. Now here, vertebroplasty can give rise to a cement leak or aseptic loosening or a neurodeficit, and hence additional fixation and fusion is recommended. Initially, 1 up, 1 down was recommended, but to prevent implant failure, 2 up, 2 down was recommended. But even then, implant failure is not uncommon. And hence, many surgeons, they recommend doing an anterior reconstruction with or without a posterior column shortening. The problem here is the long segment of fixation, which can give rise to adjacent segment fracture. And this long segment are morbid in elderly patients who harbor this fracture. And hence, in order to reduce the length of construct, cement augmentation is of value. With this thought, we carried out this study where we evaluated all our osteoporotic burst fractures with intact neurology. After applying the exclusion criteria, we had about 33 patients where we did a short segment cement augmented fixation, and we followed them up for more than 12 months. So we had a cohort of 33 patients whose average age was 72 years and a bone mineral density of minus 3.1. Majority of the fractures are in the D12 and L1 vertebral body. And it is important to note that majority of our patients, they presented late, that is about 60 to 120 days after the initial detection of the fracture. After the surgery, there is about 5 to 10 degree of kyphosis correction, which is mainly because of positioning. But it is important to note that this is maintained even at the final follow-up. We had patients having significant improvement in their pain and disability scores, and we had no major complications. The only complication that we saw were asymptomatic cement leaks, which were into the venous plexuses. Now, there are two similar studies, one which was published in 2015, which had Kummell's type 2 and 3, and they did percutaneous short segment fixation. They had no adjacent segment fractures. And another study which was specifically for Kummell's type 3. But here in this study, they had short and long segment fixations, and so they had adjacent segment fractures as well, and they did an open surgery, and so they had wound-related complications as well. So the beauty of this percutaneous technique is that you can mobilize these frail patients as early as possible. And in cases with complete collapse of the vertebral body, you can maintain their alignment, you can prevent delayed neurological deficit at 1 to 3 years follow-up. This technique is of value when you are treating patients who have degenerative changes lower down. So this short segment gives you more mobile segments and prevent those degenerative pathologies lower down from becoming symptomatic. So I can safely say that this is a minimally invasive technique. It has a better pull-out strength and it gives a 3-column support. Yes, of course, there are limitations and this needs to be rectified by multiple comparative studies. But at present, I can safely say that this technique is very effective for treatment of Kummell's type 3. Thank you.